right, good morning, everybody, and welcome to Pediatric Grand Rounds. Most of us are virtual today, but thanks for being here, both virtual and if there's anybody in the auditorium today. For those of you online, the usual reminders, please make sure to stay muted during the presentation. And if you have questions or comments for our speakers at any time, feel free to add them into the chat with everyone box, and I will be able to share your questions with our speakers during the Q&A at the end of the hour. You'll also be getting an evaluation by email at the end or sometime today from our team. Please make sure to fill that out for us. And finally, the planners for Grand Rounds have no relevant financial relationships to disclose. And from here, I'll introduce our two speakers for today, and then I will let them take over. First, I will introduce Dr. Yolanda Evans, who is a member of the Division of Adolescent Medicine at Seattle Children's Hospital and Associate Professor of Pediatrics at the University of Washington School of Medicine. She completed her fellowship in adolescent medicine at Seattle Children's and the University of Washington, including an NPH in health services in 2011. She's currently the interim head of the Division of Adolescent Medicine, as well as the medical director of the Adolescent Medicine Outpatient Eating Disorders Clinic. And Dr. Cinta Flynn, who is an assistant professor at the University of Washington School of Medicine and a clinical psychologist at Seattle Children's Department of Child and Adolescent Psychiatry. She received her PhD from Vanderbilt University in Nashville and completed her residency and fellowship at Seattle Children's and the University of Washington. Dr. Flynn has been on staff at Children's since 2007. She's an attending psychologist and the director of the Eating Disorders Recovery Program. Thank you so much to both of you for being here, Dr. Evans and Dr. Flynn. I'll let you take it from here. Thank you.
Thank you, Dr. Mazur. So just really privileged to be here talking with everyone today. And our presentation is entitled Responding to Crisis in Youth Eating Disorders, Innovative Solutions and Opportunities for the Future, because we have definitely had to be creative and thoughtful about addressing the needs that have happened over the last few years. So we'll give you an overview and then look forward to responding to questions at the end if there's time. All right, and so we're going to be going back and forth, handing off between the two of us over the course of the hour. All right, so our objectives for everyone today, at the end of our presentation, we hope that you all will be able to understand changes in youth eating disorder presentation over the last 3 years, so over the course of the pandemic, describe the support needs of families seeking recovery and support for youth with an eating disorder, and identify challenges and opportunities for innovations in clinical service delivery. And neither myself or Dr. Flynn have disclosures. All right, and so this is our agenda for the day. One thing that we didn't put in here that I know the University of Washington and Seattle Children's generally pause to acknowledge, so I'll go ahead and pause now, is both land and labor, and just to pause to note that we are residing on the traditional land of the Duwamish, and a pause to acknowledge the labor of people who were enslaved from the continent of Africa and brought to the U.S. And really helped build our country, our institutions, and the ongoing unpaid or underpaid labor of immigrant people, youth, students, as we continue to do this work. So for our agenda, we'll talk about the national emergency, as it was called, some challenges to the provision of care, both what was going on before the pandemic, during, and now in our post-pandemic world, which it feels still very odd to kind of say post-pandemic. And then some of the ways that we've responded to the challenges in our clinical delivery of services, and then we'll talk about future opportunities. All right, so we'll start with the national emergency. So I know that this slide has a lot of information here, but want to remind everyone that eating disorders are biologically based and very serious mental health disorders that do have physiologic complications, cognitive complications, and of course, emotional complications too. And they do severely restrict life activities. And between 5 to 9% of the US population, or up to almost 30 million Americans, will have an eating disorder in their lifetime. And this is a disease that starts in adolescence, which is why we're both here talking today. But just want to really emphasize the relevance to all of us as people who are in pediatrics, that the typical age of onset for anorexia nervosa is early to mid-adolescence, and similar age of onset for bulimia nervosa. And this onset really peaks between 14 to 18, which is right along the ages of youth that are coming into our adolescent clinic. The age of onset for ARFID, or avoidant restrictive food intake disorder, can range from younger age children through adulthood, and it really depends on the type of ARFID presentation. And just again, most people who have the onset of an eating disorder, approximately about 85%, are going to start having symptoms before adulthood or before the age of 20. And another reminder to everyone that eating disorders are not determined by race, gender identity, socioeconomic status, sexual orientation, and really they can affect any and everyone. And so when we're talking about eating habits, body image with our patients that come through, really checking ourselves for bias, stereotypes, and assumptions as we're going through our process of screening and asking questions, and not making any assumptions about someone based on their body size or their demographics or other things that we may have in our mind as like the stereotypical person with an eating disorder. And we are seeing increasing prevalence of people who identify as males, of underrepresented minorities, and even younger age children who are presenting meeting diagnostic criteria for eating disorder. And why are we here talking about this? It's because this disease really is serious and has very high morbidity and mortality. It has the highest mortality rate of any psychiatric disorder, 12 times that of all causes for female identified people ages 15 to 24 in terms of annual death rates. And death from eating disorder is most often secondary to complications of starvation or suicide. We also see that youth with bulimia nervosa um, may appear to that self-injury, substance use, and other impulsive behaviors may appear to be less common in the younger adolescents with bulimia nervosa than older teens and adults. But we often are seeing comorbid behaviors related to mental health, depression, anxiety, non-suicidal self-injury, substance use. And so, as we're screening for youth with an eating disorder, not forgetting that we need to be talking about other risk behaviors and things that can impact health as well. The good news is that we can intervene early and people get better. Most patients do fully recover. The recovery is a term that has various definitions, but weight restore and are able to live their lives. Anorexia rates of chronicity really range between 7 to 15%, and that's defined as having the disorder for more than 5 years. And the prognosis is better when we determine that someone has an eating disorder in adolescence and are able to intervene early. Of those with bulimia nervosa who receive treatment, 50% are symptom-free 5 to 10 years later, though half continue to exhibit some disordered eating behaviors and symptoms. So, I think I'll probably lean on Cinta to talk more about that, but really, early intervention, not waiting, is so key and critical to helping people into recovery. All right, I'll turn it over to you, Dr. Flynn. Oh, I can't hear you. Still can't hear you.
Okay, there we go.
There we go.
Did we skip over a slide there? Maybe. Can we go back one?
Oh, we did. I'm sorry about that. Thank you. So Again, we call this section the national emergency, and here's why. So this is from 2021, October of 2021, and all can read it, but I'll read it out loud. Today, the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association together, representing more than 77,000 physician members and more than 200 children's hospitals, declared a national state of emergency in child and adolescent mental health and are calling policymakers to join them. So, Dr. Flynn will talk a bit more about the changes that we've seen over the course of the pandemic. Thank you for that.
Yeah, so I'm going to talk about we're going to really identify some of the challenges for providing care pre, during, and post-pandemic. Next slide. And we'll start off about talking about just some of the data that we have that supports that statement by those three groups that this really is a national emergency. And I really want to, we're bringing in pre-pandemic information because one of the things that we really see is that the mental health crisis for youth was really brewing before the pandemic. So even then, up to 20% of 3 to 17-year-olds in the US had reported a mental health disorder. In 2016, there were 7.7 million children with a recognized mental health disorder. And it's important to note that half of them did not receive adequate treatment, even though many of these things are treatable. We do have interventions that we know can be effective. There was an increase from 2009 to 2019, so all pre-pandemic, in the proportion of high school students that reported persistent feelings of sadness or hopelessness by about 40%. From 2011 to 2015, youth psychiatric visits had increased by 28%. From 2007 to 2018, suicide rates among youth ages 10 to 24 in the US had increased by 57%. The National Center for Health Statistics suggests that there were more than 6,600 deaths by suicide among this group of 10 to 24-year-olds in 2020. So getting into the pandemic there. Next slide. And then what we saw, so we have this developing trend, and what we saw during the pandemic was an exacerbation of that. So overall, there was a significant increase in youth seriously considering suicide, making a suicide plan, and attempting. In early 2021, emergency department visits in the US for suspected suicide attempts were 51% higher for adolescent girls and 4% higher for adolescent boys. And that adds on to what we saw up to 2019. There was a greater than 40% of high school students reported that they felt so sad or hopeless that they couldn't engage in their regular activities for at least 2 weeks during the previous year. This is all from 2021. 20% of female students experienced sexual violence during 2021, and 14% of them reported having been forced to have sex at some point in their lifetime. Approximately 60% of female students experienced persistent feelings of sadness or hopelessness during 2021, and a quarter of female students had made a suicide plan. 70% of LGBTQ plus students also experienced persistent feelings of sadness or hopelessness during 2021, and greater than 50% had had poor mental health reported during just the past 30 days from when they were surveyed. 25% of them attempted suicide during the past year. Next slide. Specifically, with regards to eating disorder, the CDC put out a report covering the period of time from January 2019 to January 2022. And during that time, they broke it down by disorder, more so than behavior. So during that time, Weekly emergency department visits among adolescent females increased specifically for well, for two mental health conditions, eating disorders and tic disorders during 2020. There were 4 disorders that increased in 2021, also included eating disorders, and 5 in 2022, also including eating disorders. Overall, the proportion of emergency department visits for eating disorders doubled among adolescent females in particular. And just as an aside, tic disorders tripled during the pandemic. And we might think of those things also as having a strong connection to anxiety. Next slide. And this is just from a report from a hospital in the Midwest that they had the total number of admissions between April 1st, 2020 to March, a year later in 2021, was more than double. So they had a 123% increase in the number of admissions compared to the previous 3 years. Next slide. So what happened here at Seattle Children's? We saw very similar things to these national trends that we're talking about. This is a graph of the number of inpatient admissions to our eating disorder refeeding clinical pathway. And you can see that prior to about 2016, we were obviously admitting kids for treatment of eating disorders, but fairly stable numbers, some ups and downs. We had a big increase in 2016. And then again, sometimes we kind of drop back down a little bit, but not to our pre-2016 levels. And we've really had an increasing trend occurring even before the pandemic, and then during the pandemic from 2019 to 2021, we had a 28% increase. We have had our numbers come back down a little from 2021 to 2022. I think it's too early to know if that's a trend. We're certainly hoping so. And then there will be, if we do find that it's a trend, there are a number of factors that might have contributed to that. And some of that we'll just have to wait for that data to come in. But we are hoping that some of our interventions might at least be part of that picture. Next slide. So I just want to sum all that up. We've basically been describing the terrain and the challenges that we recognized that we needed to address. So one, we started with talking about how eating disorders are a very serious mental health disorder that are treatable, particularly with early intervention. But they do require specialized and coordinated multidisciplinary care. Two, we see a trend nationwide and here in our region of an escalating prevalence before the pandemic and particularly during those pandemic years. Three, we have not mentioned yet, but we had an inadequate infrastructure going into this. We had somewhat limited outpatient resources in our area, particularly across the state. We had limited sort of the interim levels of care that we talk about, residential, intensive outpatient, and those systems became very quickly overwhelmed. Wait times during the pandemic became just completely unacceptable. Providers stopped adding to their wait lists because wait times became like up to a year to be able to get in to see therapists. There were long wait times for residential facilities, and we saw the increased admission rate to our hospital. And there are, everyone is probably aware that we have inequities in our healthcare system in general. There are inequities in our mental health care system. So all of these things were exacerbated for people who already had less equity in terms of accessing the healthcare system. So while the disorder itself does not discriminate across socioeconomic or other lines, our healthcare system does, making it more difficult for people with no or Medicaid or state insurance to be able to access the already limited care. Next slide. And so we're going to talk about responding. How did we respond? Or how have we been responding to some of these challenges? So one of the things we wanted to do, we recognized that we really you need that multidisciplinary and well-coordinated care. So this is just kind of a graphic, the way we think about it. We are in different departments, but we have really been moving to becoming not siloed, but a village that works together. I am going to describe some of our innovations in psychiatry, but I do want to highlight that all of these things have been in collaboration with our partners from adolescent medicine and nutrition.
And I'll just add to this slide too. This slide looked very different a few years ago. I think we've done quite a bit, as you'll hear about, to really become more of a village than a standalone like dwelling with nothing surrounding. Um, and I think we don't have our nutrition partners here today too, but just want to highlight their participation and involvement in all of the different changes that have happened, and social work involvement, and all of our other team members too, who help with coordination and nursing and all of the other supports that go into the structured changes. And just noticed a comment too that we'll probably get to it a little bit in the chat from one of our team members too about the change in our criteria. I didn't get to see the whole thing, but we'll get to that. But we did have to make some really drastic changes, just to kind of take us back a little bit. What Dr. Flynn was saying, we saw significant increases on the inpatient side, and we saw that on the outpatient side too. And we also saw a lot higher acuity on the outpatient side for lots of reasons, but all related to what we've said so far with limited access, delays in care, hard to pick up and intervene on things, even when family members are worried. We didn't have people in schools with other eyes on them to give feedback and help share when they're worried either. And so we had to make some changes because we were seeing kids who were really sick in the outpatient setting, and we were quickly inundated and at max capacity and had long delays and wait lists for people to get their first appointments. And also, we wanted to really make sure that what we were creating was gonna not exacerbate inequities or worsen them. So we didn't want to create systems where people could jump the queue and get in earlier if they just made a call, or for families who speak a language other than English, we didn't want to create barriers, that would prevent them from getting in any worse than what we already have, with needing to call in and things like that. So we're going to talk a bit more, but just to acknowledge all of the different challenges that were happening that led up to the really significant changes. Right. So I'm going to keep going.
I think
Did we lose? Uh-oh.
I'm not sure. It seems like our slides went away.
I think my WebEx just chose to update just now. Hold on one second. That is so fascinating.
Huh.
Yolanda, if you reshare, it should just pop us right back in. Just a moment. Emily is going up to help unmute people really quick.
Oh, there we go. Okay, let me try again. It did, like, I see my phone is doing odd things. I think my like WebEx app like just decided to update. Okay, let's try sharing again. Okay,
There we go.
there. Technology. All right, here we go.
Okay, so I'm going to talk a little bit about an overview of some of our programs that we developed together and in psychiatry. And I also want to acknowledge that a lot of this was made possible from the generosity of some of our philanthropic donors. Um, so that's wonderful. I just wanted to mention that. Next slide. Okay, so one of the first things we wanted to do is we wanted to have greater accessibility to our eating disorder outpatient clinic. We had one before, but it was small and not at all able to manage the number of referrals that we were getting. So we were able to increase our outpatient capacity, and we added a number of providers that are able to provide assessment and diagnostic consultation. Mental health therapy, we provide both individual and family-based treatment, and we have a number of group therapy options. And we really moved also to enhance our case management. I think one of the things that we have found is that is very helpful for families to overcome some of the challenges in terms of access. One thing I'll note is that we have a 34% increase since January of this year, where we have been able to have some of the patients who are admitted to our clinical pathway to be able to then discharge to our outpatient mental health therapy in our clinic. And that's just in the last few months. We also looked at some of our models for care and where we could, specifically for treatment of ARFID, we developed a step care model, which means that we can take in that all of our families for who need treatment for ARFID start in a multifamily group therapy, which has allowed us to treat far more people than we were able to before. And then at the end of that, there are potentially options if needed, and in a lot of cases it's not, to continue on with some kind of individual therapy. We have gone from having, we were one of the people who ended up having about a year-long wait time, and ended up needing to stop adding to our wait list at one point. And we are now down to approximately just 1 month for a new visit or an assessment, and only 1 to 2 weeks wait time for therapy. For patients and families coming out of our medical setting, they do not have to have a new visit because they've already met with our team on the medical floor. So pretty short wait time comparatively. And for our clinic, we usually take internal, like from our for kids on the medical floor, or PCP or mental health therapist referrals for psychiatry. If people are thinking of referring. Next slide. We have all, that's it. We've also developed something we're calling the brief transition support, or BTS. And what this is it's approximately a month of services that will include an initial assessment if needed, mental health therapy, again, our from a family-based model, but individual and family and group, and also are utilizing our enhanced case management model. Um, this is for patients who are sort of both coming and going. So if someone comes into our emergency department and they don't require medical admission, we ask that they get referred to our BTS program. And Yolanda's going to talk a little bit about the hospital transition support. So this is very much a collaborative model with adolescent medicine. But then rather than just go home and wait and come back, they can come to our BTS program, and we are working to avoid them coming back and needing medical admission by offering these services. It's also for patients who are being discharged from medical admission so that we can provide a bridge to the next step in treatment. Um, if it so if they're waiting a couple of weeks to get into our outpatient clinic, they can start here and if need be and have that time. Or if they're waiting to go to a higher level of care or something like that, this is an option. There is no wait time for this service at all. And this is internal referrals only from our emergency department or inpatient medicine. Next slide. The other thing that we did is recognize the need for really intensifying our psych support for patients who are medically hospitalized. So what used to happen was it was our psychology consult liaison service that would get referrals for these patients and evaluate and try to follow them during their admission. What we did is now we have built a specialized kind of branch of our CL service, our eating disorder service. And what that includes is virtual meal support. We started that way. We are continuing that way, even though that some of our COVID restrictions have dropped. But we're continuing that way because then we're able to include patients from different areas in the hospital. And we really don't have a space right now where we could have kids do this together in person. And I think that's something we would hope for in the future. And that team, the Recovery Allies, also offers supportive groups. And their programming is available 14 hours a day, 7 days a week. They've also gone in and helped coach one-to-one at times for patients when they particularly need some extra support. There are 2 mental health therapists with the eating disorder service that provides patient therapy at least twice a week, and they are available 5 days a week. We also have case management, and this goes back actually to 2017. We had initiated the twice a week multidisciplinary rounds that probably many of you have been involved in. We have 2 attending psychologists that provide the initial assessment and then family-based treatment caregiver sessions, and we provide caregiver meal support training. And I know we are actively looking at models to increase our support for caregivers to build those meal support skills. Our ultimate goal is to really get kids home. Next slide. The other thing that we have been doing is so that people don't just necessarily have to come to us, is we have a entirely philanthropically funded eating disorder treatment network, or our EDTN. It was developed in psychiatry with partnership with adolescent medicine and nutrition. And the specific goal of this was to increase equitable access to mental health treatment of eating disorders in youth across Washington state. What we did is we initially targeted community mental health therapists, people who are working in community mental health centers that take Medicaid insurance. In phase 1, we really wanted to get a lot of training out, so we were broadly inviting people to join a 20-hour workshop, and then some subset of them could also participate in 12 sessions of facilitated group consultation with us. And we did 2 rounds of that. And then we did a more targeted intervention where we asked everyone who signed up for the 20-hour workshop to participate in that facilitated group consultation. So we both wanted to raise awareness and some basic skills, and then we really wanted to train people so they would develop confidence and be able to treat eating disorders in their setting. In total so far, this is an ongoing project. In total, we have had 110 participants from 18 organizations across the state, and 33 of those are ongoing community partners, meaning that those are people who are now actively treating eating disorders in their setting. What we're working on now is having an ongoing network for all past participants. We've recorded some of our training so it can be virtual, so really any therapists in our state can log on and participate in that training. We have continued consultation groups or office hours that are drop-in for people treating eating disorders, and it is open now to all providers. There is no fee for this service. Continuing education credit is available, so that is attractive, but we do ask for people to commit to treat eating disorders because that really is our mission. And we've had some good results. People have reported that they do have greater confidence in working with these patients. Next slide.
Right, thank you, Dr. Flynn. And so I will talk about some of the changes. I couldn't capture all of the changes, but some of the highlights that have kind of paralleled the work in psychiatry that we've incorporated into our clinic and clinical work in outpatient and some of the inpatient work for adolescent medicine. All right, so I think one of as we've talked about, the increase in referrals, and one of the things that we had to do was change how we were having people come in so that we could accommodate the increase in referrals. So before, we had a variety of providers who were seeing youth for support around eating disorder, and there were a number of different requests for information that we asked of referring providers, including labs, EKG, orthostatic vital signs, and a lot of other information that was really important for setting us up to be able to intervene in the care. But what it ended up doing was kind of siloing in people who were the most acute. So we were seeing patients who were meeting admission criteria. Almost all the new visits, it felt like, were meeting admission criteria because it was taking so long to get people in, but also because it was such a complicated process to refer into. The other thing that was happening was we were following patients for extended periods of time. So, me personally, I had some patients who I've probably been following them for 8 years, from age 10 or 11 all the way up now into emerging adulthood. And we didn't really have a plan or strategy for helping them transition either out of our adolescent clinic or for the warm handoff or transition back to their primary care provider. And so we really wanted to try something new. And so in 2020 to 2021, we had a pilot project of offering a telemedicine intake where we would take people who were referred in and offer them a telehealth visit so we could get them in quickly. We could talk through what was going on, review records, and then offer them a diagnosis. And instead of just assuming that everybody would come into our program, offering families the option to opt in or opt out. And if they opted out, we would set them up with resources. And so in January of last year, we said, okay, let's try this. It worked really well. The feedback was wonderful. And me and one of the other providers who piloted this kind of manually captured feedback from all the referring providers. We called them all and asked, their thoughts and asked families too. And since it was positive, we said, let's try incorporating this. So we actually have now shifted to offering a telemedicine intake. So if somebody comes through the emergency department, instead of waiting in a long queue or kind of waiting to get sicker or not having any services, we've got the BTS support, and the primary care provider can refer in to get a telemedicine intake and evaluation. And so we've really tried to simplify our referral requirements to just the last set of vital signs. And we're not asking for labs, EKG, and all of that information. Though with Epic, it makes things a lot simpler to be able to look in if people are receiving care in a system that also uses Epic. And then we are offering a diagnostic evaluation with the goal of being able to offer a probable diagnosis and then help in collaboration with the primary care provider to support the families. The telemedicine intake can lead to a few different outcomes. So people can opt into our outpatient eating disorder program, which I'll talk about next. We aren't including ARFID and binge eating disorder in that at this point, mainly because we don't have really great evidence-based approaches to the medical management for those. And we're also offering people, if they don't want to opt into our outpatient program or it's not going to work for the family, then we're still offering our social work support to help with resources and identifying options in the community that could work for them. We really have a strong need to collaborate with our community partners, our community primary care providers, because there is a bit of a time window, a month or two between that telemedicine visit and potentially the outpatient eating disorder program because it's a series of appointments. So we're also hoping to transition people back to their primary care provider once they've had a good weight trajectory of restoring and are settled into meeting with a therapist or more stable. And then for those who do enter into our outpatient program, we are definitely offering the interdisciplinary team of providers in adolescent medicine. And so all of those families receive a nutrition telemedicine intake appointment and social work intakes. And those visits are really critical for setting expectations, boundaries, clear goals of what services and the why for entering into the program, instead of kind of an indefinite, not really goal focused approach to care. So this, I didn't put data in here, but our program coordinator, who's also a new role over the course of the pandemic, and I looked at some of our dashboard data a couple years ago, and we noticed some really positive trends with this that we have seen that our families who request a language other than English have gone up. Our number of patients with Medicaid or government insurance has also gone up. So we've been able to serve a more diverse group of youth by kind of opening up our services in a way that also is time limited, but allows people to have very set expectations and clear resource offering. So we'll talk about we call it op-ed, but our outpatient eating disorder clinical program. And so we've set this up as kind of a 12-week intervention. So not to say that we only see people for 12 weeks, but we're going to start with 12 weeks, have very clear expectations with families. And the goal is to offer the medical appointment with our adolescent medicine providers every other week and nutrition appointments about once a month. Though we can move those around if we need to. They could be nutrition appointments every other week too, and medical once a week. It just really depends on, the needs of the family. But we start out with every 2 weeks medical, once a month nutrition with social work support as well during those visits. And at the 12-week mark, we have a visit where we reassess. Have we made progress to our goals? Is the disease worsening and now we need to look at higher level of care? are we stable and we can transition back to the referring provider? So the pathways for referral into op-ed are through our telemedicine intake evaluation, which again is really critical because we want to allow families the option to opt in or opt out and really help them understand what the commitments are when they opt into the program. And we want to make sure our primary care referring partners are in the loop and communicated with. The other option for entry into our op-ed program is the hospital transition support, which Dr. Flynn already talked about a little bit, but I'll talk about in more detail in just a minute. And so for patients who are leaving the hospital from a medical stabilization appointment admission, we have created a service to offer some bridge support. And so those families can also transition into our outpatient program. We did have to make some hard decisions, right? And one of those was asking for a primary care referral, um, really because we are relying on those PCPs for interim visits, for setting up um, supports and plan when they leave our services, for making sure that we're communicating about patients who are going to higher level of care. Because part of what was happening before was we were receiving calls from community providers saying, hey, I had no idea my patient was going to that residential facility. Or we had families who were leaning on us for primary care need or attempting to lean on us for primary care needs because they hadn't seen their PCP in a while. And of course, like I said before, this is 12 weeks, but we do have the opportunity to expand for an additional 12 weeks to work with the families around their needs. I'm not going to talk a lot about the inpatient consult service. Dr. Tarnay Shafee is our inpatient consult medical director, and Rachel Vivoda is our nurse practitioner lead on the inpatient side. But they have also been working really diligently to make changes and in collaboration with our psychiatry partners too. I did put the link here for everyone. If you don't know, there is the refeeding pathway on seattlechildrens.org that has a lot of great information around admission criteria, what happens in the hospital. Some of the things that Dr. Shafee and Rachel have done are really change our materials to be able to help families understand what the services are that they're receiving when they are admitted to the hospital, who the team members are, and really, again, setting expectations and helping ground people to what this disease is and how you progress through to recovery. The Some of the other kind of changes that have happened on the pathway, we've increased the starting calorie amount because there was some really good evidence out over the last couple of years about how starting higher is safe. And we've increased more rapidly in order to hopefully restore weight faster and decrease length of stay. And avoid delays in getting people into the care they need, because as we all know, when you're admitted to the hospital, you're not really engaged in as many of the really needed mental health interventions for this disorder. The Centene team have really ramped up the mental health support significantly. We've also added Rachel, our full-time advanced practice provider, and we have an APP fellow who's participating on the consult service, and the residents too are rotating through. And so the other big change is now there is a bridge support in our outpatient clinic for people leaving the hospital. And so we call it HTS together. So we have BTS and HTS, but hospital transition support. It's also about a month of weekly visits. So we offer up to 4 visits over the course of the month. And it's again the interdisciplinary team. We have medical provider, nutrition support, and social work support, in addition to our nursing support, medical assistants, and everyone else in clinic. And this is specifically a bridge support for families, because this diagnosis is overwhelming. There is a lot to coordinate, a lot of resources to put into place. And oftentimes it takes a while for it really to kind of the understanding of what this is going to entail to sink in. And during that hospital stay, it's not always clear, like, okay, this is what we've got to do now. And so for families, and so we want to help support them. And so we've created this service. It really allows for reinforcement of our discharge treatment guidance, and helping with resource support, and helping with engagement in outpatient care. And it's a bridge to, as oftentimes, like Cinta was saying, there's not a spot at a higher level of care facility when people need it, when they're in the hospital. And so they have to wait for a month or more. And so this is a way to offer some bridge support as people are transitioning into a higher level of care from the hospital. And it's a pathway into our op-ed program as well. So this is another very exciting development over the course of the pandemic that we've been able to create. And this really lines up well with the BTS support. So people are able to have both the mental health and the medical and nutrition support when they're leaving the hospital. And this is one for internal, again, internal referral only, for patients who have been admitted to the refeeding pathway. All right, so I'm going to turn it back to Cinta to get us started talking about some of the future opportunities.
And I know we want to leave a little bit of time for questions, so I'm going to say overall, our current plans and hopes are we are going to continue to work on the services that we have built in the last couple of years. And we also have lots of ideas for things that we're doing, and a few of them we have mentioned here. One project that is well underway and about to roll out in terms of a pilot is a project that really involves having our CNAs get some training in eating disorders, and we've identified some phases in treatment and different levels of CNA support. So there would be people in the room with the primary goal of them actually being able to coach patients, coach and encourage patients to join that virtual meal support and some of the groups, the therapeutic groups that are offered, and also provide us some data from direct observation during the day. I want to mention Sarah Mahoney. I can't see everyone who's here, but Sarah Mahoney has really been working with us on the pathway and taking the lead on getting that project rolling. We've also been working with nursing. There's actually a long list of people that I could mention, some of whom I do know are here. So it's exciting to see that coming to some fruition soon. We are working on a specialized clinical pathway for avoidant restricted food intake disorder. One of the things that we know is that that some of our patients with ARFID don't always, they need some modifications to the current pathway in terms of their food choices and nutrition and some of the consults and even our treatment that we offer in psychiatry. So that project is also up and running. And so there will soon be more of a specialized pathway for ARFID. We are also thinking all the time about ways that we can improve and potentially expand our services. I think I mentioned earlier that there are situations in which it might be nice to have our patients co-located, to have some room to have sort of more in-person groups and things like that. And it would just give patients also opportunities to sometimes be able, when they're able to, maybe get out of the room and join a group or something like that. So those are some things that we're looking at with the hospital. And I know Dr. Evans and I have spoken a lot. There it goes again. We've spoken a lot about how we deliver services. So there was a study that came out recently from the folks at Stanford who developed largely involved in developing the family-based treatment models, which is the recommended standard of care for adolescents with anorexia. And they looked at some of the data from their RCTs and of people who participated in those studies. There weren't any demographic variables that predicted outcome. And what that would suggest is that the therapy, if delivered, can be effective across demographic variables. What Dr. Evans and I have spoken about quite a bit and are in the process of making plans of figuring out a way to actually study is how that the way we deliver it is more of a is something that we need to be thinking about, so that we can make sure that people can get into a therapy that we know works. And we've talked about some ways that we've tried to address that, and I think we feel like there is even more that we could do in terms of making it more accessible to families who may not have the certain luxuries that other families have, like FMLA or things like that, that allow them to participate in, even at an outpatient level, a fairly intensive amount of care. So that's a project we're working on, and I'm going to hand it off to Yolanda. I think we had one more slide after this one, but we can share those later, but I'll hand it off to you.
Yeah, thank you. I'm sorry. I think that my WebEx app is just not cooperating, but we had a slide of resources and evaluation slides. I'll try to share those before we're completely done. But just to add to one of the other things that I wanted to call out is, from future opportunities and what's happened, our social work team has created and been offering a support group, as Cinta mentioned, more supports for caregivers in the outpatient setting too. So we have we call it Mars to go with the star. There are lots of various groups. Thank you, Cinta. And we're also, on the outpatient side, continuing to look at, how can we provide care that's safe, evidence-based, but reach as many people as possible and decrease any barriers for community providers to getting patients in who need the care. So lots of work happening and in multiple different venues, inpatient, outpatient. And I think we and psychiatry have really been intentional about partnering more. And so if you go on to seattlechildrens.org and look at the website, you'll see it's now the Eating Disorders Recovery Program on the website, and that we're both there together. And you can reach resources from both of our departments in the same spot, which is a brand new thing. Thank you, Cinta. And we've also been updating our eating disorders patient education toolkit on Child on that internal server as well, and creating resources for parents, caregivers to help them on this journey. And then we're trying to, disseminate work as well. So have some internal projects and working with Nicole Stetler on a project to prevent eating disorders and doing more collaborative things too. So it's very exciting times and a lot of creative innovation. So I know we only have 2 minutes left. Thank you all.
Thank you so much. I mean, most of the chat is actually dedicated to saying thank you. It's actually so amazing from the ED and also looks like the PCP standpoint to see how care has expanded over the recent past. You touched on this a little bit, just a question from Aaron Whiteman. If you can address this in the last 1 minute. Congratulations on innovating and expanding services for this population. My question is how the services and models described can continue without reliance on philanthropy and an environment of increased restrictions on telehealth visits. I don't know if you can address that in 30 seconds.
I know, I'm like,
it's a great question, Aaron. Thank you.
It's such a great question. I think on the adolescent medicine side, we have not had any philanthropy. So shout out to anyone who wants to donate and support. But the telehealth part is really critical, and we've set it up so that the medical provider is the one with the appointment, that main appointment, and have a little bit of a longer visit so that we can bill for the time. And that was intentional in that regard. Uh, and we are going to have to transition some of our initial intakes and things to more in person, as time goes on, most likely. But we want to keep our model because it's been so impactful for families to be able to get the service quickly and decrease barriers to the services. So I'll turn it to Cinta.
I will just add that in psychiatry, we are still able to do telehealth, and we now offer both, and even potentially both for a single family, so that some can be by telehealth. We do plan to continue doing telehealth visits in psychiatry. One of the, at least for some of our families, one of the things that we found is that it is really helpful for us to be able to provide care to people who are like in Eastern Washington or something like that. In terms of philanthropy, we are planning and hopeful to move a lot of our services to budgeted services so that we can continue those and they can be a stable part of what we provide.
Thank you. Thank you both for your deep thinking, all of your hard work, and to your whole team for expanding services for this really, really important population. Thanks for your time this morning. Our time is up. Thanks to our audience on WebEx and in Wright Auditorium for your attention today. And no thanks to WebEx for not working perfectly for us, but it was a great hour and we all really, really appreciate your time and all your hard work. So thanks everybody. And for our Grand Rounds audience, we'll see you next week. And Yolanda and Cinta, look at the chat because there's just a lot of thank yous for you and I don't want you to miss them. So thanks everybody. See you next week.